Well, good evening, folks. Dr. David Rawson, President and founder of the Canadian Academy of Clinical Sleep Disorders Disciplines, a mouthful, CACSDD for short. It's my pleasure to welcome you to webinar number 9 for this evening. And we have back a speaker highly recommended and appreciated in the past, Dr. Dennis Bailey. You may remember spoke to us live when we had an in-person meeting last was 2019. He also gave us a webinar in late November. The title was The Nose Knows. Tonight, Dr. Bailey is going to present phenotyping and endotyping in dental sleep medicine. And without further ado, welcome back to Canada, Dr. Dennis Bailey, now of Nashville, Tennessee. Welcome, Dennis.
Thank you, David. It's a pleasure to be with all of you again. I look forward to hopefully stimulating you in terms of this very interesting arena, I'll call it, of phenotyping and endotyping. It's kind of the buzzwords that we're hearing and seeing in the literature these days regarding not just dental sleep medicine, but sleep medicine as a broad discipline. What I want to do tonight is look at it in a way that is applicable to dental sleep medicine and sleep breathing disorders. So it will take on somewhat of a flavor associated with all of those categories. We'll look at evaluation and management implications. So without further ado, let's go to the next slide. I want to first of all stress that dental sleep medicine now has an updated definition, which is based upon, to some degree, this symposium and article in the Journal of Oral Rehabilitation. The symposium was in 2019. The Journal of Oral Rehabilitation article was in 2020. And basically, this is an aggregate of individuals, all of whom you're very familiar with, that met and discussed how dental sleep medicine is no longer really just about sleep breathing disorders and oral appliance therapy. It now encompasses sleep bruxism, which many people have already done, orofacial pain, which is to a lesser degree being done, and related medical conditions such as gastroesophageal reflux disease, headache, insomnia, restless leg syndrome, periodic limb movements, REM behavior disorder, and a myriad of other conditions that are all associated with both sleep bruxism as well as sleep breathing disorders. And orofacial pain is not being viewed now just as TMD, TMJ. It takes on a very broad category of neuropathic, vascular issues, mostly neuropathic issues, as well as myofascial issues that are related to it. Many of you who have been in this field a long time, I'm sure, know what I'm talking about. So dental sleep medicine in the 21st century, according to the symposium and the article, is a bidirectional association of orofacial pain and sleep disorders, not just sleep breathing disorders, but sleep disorders in general. The association of sleep bruxism with other sleep disorders as well is covered within this entirely new definition of dental sleep medicine. And sleep bruxism itself is now being viewed based upon current literature and research that's been published. And I refer you mainly to the Journal of Oral Rehabilitation for a lot of the more current research. But sleep bruxism is now viewed as more of a behavioral issue versus a disorder. This kind of takes it into a different realm when we consider the fact that sleep bruxism historically, according to the ICSD-3, has been considered a movement disorder akin to RLS and PLMs. This dental sleep medicine in the 21st century also takes into account the role of the dentist in the assessment and management of sleep bruxism, as well as related conditions, and as we're all aware, the dental management of sleep apnea. Let's get into phenotyping and endotyping because that's really the crux of what we're talking about this evening. So what I'm going to do is try to break it down into its most simplistic definitions and most simplistic understanding, because there are a variety of crossovers that occur with much of this information over time. And I want to try to bring it down to the level of where it applies to the dentist and where it applies to the use of oral appliances for the management of a sleep breathing disorder. So phenotyping, as opposed to endotyping, refers to specific characteristics of the individual. It can be related to their genetics, to the environment, to their appearance, as well as to upper airway anatomy, their craniofacial characteristics, particularly the skeletal characteristics, ethnic and racial considerations, meaning that the Black population, or sometimes they're called African Americans, but nonetheless respond differently than Caucasians, differently than Asians, and particularly the Chinese and the Asian category, to how oral appliance therapy may work, as well as what their predilection and what are some of the conditions that make them at risk for these disorders, as well as the differentiation between the sexes, male and female. And it also looks at what are the differentiations between REM and supine-related OSA. Are there differences? Well, part of what they define is, yes, there are differences. REM-related OSA tends to be or have a predilection towards females. It tends to be seen more in the older age groups. Typically, these patients have a higher BMI. And the genioglossus in many of these cases is hyporesponsive to airway issues. Whereas supine-related OSA can be more prevalent in the males. It can be at a younger age. Children can also have it. The BMI at times can be lower, and there's unfavorable airway due to craniofacial structures. So we might see someone who has more maxillary and mandibular retrognathia, for instance. Phenotyping has 4 factors for OSA pathogenesis. First of all is the upper airway anatomy. Do they typically have a small airway, and is that always a factor? I always like to go back when I bring that up to what Christian Guilleminault published so many years ago, where he said not all patients with small airways are going to have sleep apnea. And what he meant by that was, or what he was looking at, and mainly because his thrust came from his neurology background, was that many patients may have a lack of a neurologic response, or have more of a neurologic response to either maintain the airway, or a lack of neurologic response, which allows the airway to be more collapsible. It also looks at the ability of the upper airway dilator muscles to respond to airway collapse. There's a propensity to wake from respiratory stimulus or airway collapse when sleeping, which is oftentimes looked at as a low arousal threshold. The low arousal threshold is a big factor in all of this, because if the patient is having the airway collapse associated with a respiratory event, but doesn't have the stimulus to open the airway, the low arousal threshold will lead to more apneas and hypopneas, and may even be more apneas than hypopneas in those situations. It also looks at stability of the respiratory control system, a thing called loop gain. I don't know how many of you or how much you have had exposure to loop gain. I'm going to try to simplify it a little bit in terms of what that actually means, because technically loop gain is really a electronics type of philosophy or theory based upon feedback that one might get from a system. Individual characteristics that are observed makes up the phenotype, as well as genetics and environment, as I pointed out. But mechanisms are not a consideration. Mechanisms become part of the endotype for that particular patient. So this is a breakdown of a graph that was shown in Anesthesia Analgesia as well as Lancet in 2014. And it looks at a number of the risk factors that we are all aware of. I'm not going to read them all to you. Most of them I've covered, that lead to the pathogenic mechanisms, which become the endotypes, and the possible treatments. And of course, you see the focus here is upon the CPAP device, not upon oral appliance. We're going to talk about that a little bit more in terms of where are we at with oral appliances related to CPAP, because there are some developments based upon endotyping and phenotyping that may make oral appliances a more desirable outcome. And it also points to why CPAP may fail. Endotyping now, on the other hand, is related to unique or distinct, which is personal, mechanisms or pathophysiologic conditions. So endotyping is a little bit different. There's no genetics involved. There's no environmental things involved. And this is really an individual situation, whereas phenotyping can really be a more broad generalization that can apply to a myriad of people. Obesity in this condition is related to abdominal girth and may have an impact upon the neck and tongue. And there was or has been a number of articles, one in particular published in the American Journal of Respiratory and Critical Care Medicine, that focused upon what they call the fat tongue. And they found that the tongue mass was enlarged in those people who were more overweight or obese, and that with weight loss, the tongue would become less of an object within the oral cavity and particularly within the oral pharynx, which made it less of a problem. It also looks at nasal airway resistance or restriction. We talked about that back at the end of last year in terms of the necessity it is to pay attention to the nose and the nasal airway and whether there's resistance or restriction, and the differentiation between those this pattern of resistance or restriction in daytime versus nighttime. Another entity that has gained a lot of momentum is rostral fluid shift. What that means basically is that when people are lying flat and not sitting upright or not standing, and they have edema or an extra amount of fluid that's in the lower limbs, this fluid, this edema, will cause a fluid shift up towards the pulmonary, even into the myocardial areas, and can actually end up around the neck. And they have shown with various studies that this rostral fluid shift in certain individuals, not always individuals who are obese, by the way, typically people who are more sedentary, but the bottom line is that this rostral fluid shift can actually make the apnea worse by compressing the airway from the outside inward. Many people may have many endotypes for a specific phenotype. So we can see again a broad categorization of endotypes that play into it. And once again, I want to repeat what I said early on. There's going to be some conflicts depending upon the literature. Like for instance, the one graph I just showed you with the two articles, anesthesia, analgesia versus Lancet, there was some differentiation in terms of how they categorized endotyping and phenotyping. But we'll get into how we can kind of put that into their respective boxes as we go along. Other endotypes, I mentioned rostral fluid flow. I mentioned before age. OSA, as we know, may increase with age, but tends to plateau after age 65. We know that menopausal females and postmenopausal females are very different in terms of their predilection towards sleep apnea. We know that peri and postmenopausal females are going to have a higher incidence of sleep apnea than they would if they were menopausal. We know ethnicity plays a role, and particularly when we look at the Chinese population. Almost to the day, 3 years ago, I was in Singapore lecturing. A colleague and old friend of mine who is involved with the school there invited me over. I did a great deal of research on this, and what it turns out is that the Chinese population has a very unique endotype when it comes to how and why they have apnea. And this is really not so much just in China, but is very important to the people of Singapore because 1/3 of the population is either Chinese or of Chinese origin. And so when I was talking to them about OSA and what the treatments were, we can't focus upon obesity or we can't focus upon other types of things like neck size and other factors that we might look at in the Caucasian or the African American races. Supine sleep position, in other words, positional OSA, responds well to oral appliances, as we all know. So breaking it down into more of a categorization, like I said, putting it in boxes. So if we look at OSA phenotypes and corresponding endotypes, we see under phenotypes, we can be dealing with the elderly. And as I mentioned, if post 65 years of age, it seems to plateau. We know that there's a high predilection to males. We know there's fluid overload. We know that there's changes in menopause, or there's changes associated with menopausal females. In the ethnic phenotypes, we look at all of these that are related here, as well as REM-related OSA in these different groups and supine-related OSA. When we look at predominant endotypes, we're looking at mechanisms. So we know the low arousal threshold. We know that anatomically, if they're more overweight or obese, and particularly if there's abdominal girth. We know that rostral blood flow, especially after the age of 40, can be a bigger problem. And of course, abnormalities in the fat distribution that can occur anatomically. And then anatomically, we could have craniofacial morphology, as well as alteration in craniofacial structures. We know there's hypo-responsiveness in the genioglossus muscle, that it may not be stimulated. We'll talk a little bit about that. And anatomically, there's a hypo-response related to the tongue. So basically, if the tongue is in a patient who is more obese or overweight, we're going to have a fat tongue. That's going to increase part of the problem that we have here. And a key point to take away as a message, based upon Dempsey's work in the journal Chest in 2002, obesity and craniofacial abnormalities account for 2/3 of the variations in OSA measured by the AHI. Now, I don't know where you are with looking at the AHI as a metric. I know there's a great deal of controversy about this, and especially there's a great deal of controversy about it now, based upon this endotyping and phenotyping that's taking place, because we may correct an AHI, but the patient may still have or be very symptomatic, and that could be due to some of the lack of recognition of either the phenotypes or the endotypes that are coming into play for that patient. So in phenotyping of the upper airway, the anatomy and upper airway collapsibility are key factors, again related to obesity, and particularly abdominal girth and neck circumference. Related to craniofacial characteristics such as an inferior hyoid or mandibular retrognathia, or increased cranial cervical angle, which can be related to a forward head posture and abnormal soft tissue morphology. Endotyping the upper airway dilator muscles, we see decreased tone of the upper airway dilator muscles. We see that the genioglossus or tongue is a major concern, but there's another concern that we're going to look at in just a few minutes as well, related to the retropalatal area. It can be impacted by hypoxia and hypercapnia, and of course, increased intrapharyngeal pressures, or PCRIT. PCRIT is the critical closing pressure associated with the closure of the airway when there's negative interpharyngeal pressures that are occurring due to increased respiratory drive. Stimulation of the hypoglossal nerve becomes a critical factor. And this is really where this all started, because it started with the technique of using a hypoglossal nerve stimulator, what's known as Inspire, to try to stimulate the tongue to stay out of the airway. But they wanted to have a better way to classify these patients and endotype or phenotype them so that they would know they had a responder. And there has been some investigation into medications, and combinations of medications have been tried. Endotyping related to the arousal threshold relates to the arousal index. Now, when you look at a sleep study, and a lot of times we don't see these numbers, the arousal index can be a critical factor. It tells us how much the patient is capable of responding to, say, a particular incident of apnea or hypopnea. So there are people who will have a higher AHI number, but a lower arousal index. And of course, we know that there's two types of arousal, spontaneous and respiratory. We're talking more here about the respiratory arousals that are associated with airway closure. So if their arousal index is very low, but their AHI is high, they're not going to be responding to the incident of that, or to the the apneas and hypopneas that are occurring. So their responsiveness is delayed, meaning they have a low, excuse me, I didn't mean to do that. They have a low arousal threshold related to insufficient respiratory stimulus to open the airway. Arousals can actually cause hyperventilation. This drives down the CO2 level. When it drives down the CO2 level, there's not an adequate amount of stimulation to increase respiratory effort. And consequently, we now see no arousals occurring, but yet the events are creating a closure of the airway. This results in reduced stimulation to airway dilator muscles, and particularly as it relates to the genioglossus, or to the tongue musculature in the oropharynx. Endotyping, reduced ventilatory control stability, is defined as loop gain, and it relates to a stable or unstable system. So it's how we respond to a ventilatory disturbance, meaning an apnea or hypopnea. What happens? Do we become aroused? So there's increased arousals. So the arousal threshold begins to lessen, meaning that we're more easily aroused. So do we respond to that in such a way that it creates the ability to breathe more? In other words, there's more ventilation to allow us to open up that airway. Well, if we don't, then we have a problem with loop gain. So loop gain of less than 1 is considered stable. There's no fluctuation in the breathing. I'm going to show you a little diagram that'll help to point that out. Now, once again, where does the 1 and greater than 1 come from? This is simply a way that it's been measured based upon the PSG. We don't have a PSG to use with the oral appliance to try to gauge what the loop gain is, because the loop gain is stabilized by virtue of the CPAP device. So it becomes very cumbersome to do. So we need a way as dentists, we need a way as providers of oral appliances to try to figure out whether or not there's a risk for a higher loop gain, meaning greater than 1. And that means there's an oversensitive ventilatory control system, or there's hyperventilation. Well, we're not following the patient. We don't get that data on sleep tests. We're not going to be there watching them sleep. So how do we do that? Well, we're going to get into that. So I want to give you a little more on loop gain, and I hope this isn't boring you, but this is a very important concept, and it's one that is in all of the literature. Every article I read dealing with the endotyping and phenotyping of these patients refers back to loop gain and this hyperventilation. Again, no ventilatory drive. It's a lessened ventilatory drive. Oxygen may be effective. They've gone ahead and given patients oxygen, and they find that the oxygen tends to stabilize ventilation, which lowers loop gain, which then creates a more stable effect. They've also used acetamolazide, or Diamox, which is a carbonic anhydrase inhibitor. It increases metabolic acidosis, so similar to what CO2 does, and this increases baseline ventilation. Your CO2 has to rise to a certain level for the chemoreceptors to kick in to allow for the breathing or the respiratory effort to begin to occur. And it's difficult to measure loop gain. There's been some proposals that, yes, we could do it with a home apnea or home sleep apnea test. Not very conclusive. I'll give you some other insight into how we might deal with that as dentists. Well, here's some diagrams, okay? So now in this diagram, we're starting at a lower PaCO2. In other words, that's a blood gas level, requiring more change in ventilation and the same change in PCO2, which is what the brain is going to be affected by when it comes to chemosensitivity. So we know that there's differences in how CO2 is going to affect various structures within the chemosensitive areas of the body. Now here's loop gain down here. This is what I really want you to pay attention to. Here we see a loop gain that equals 0.5. Here loop gain is 1. And remember, we want to have it as less than, we want to have it at 1. We want to have it 1 or less. So here we see that there's a breathing, there's a disturbance, and there's a response, and the response kind of tapers off and breathing returns to normal. Now, when loop gain hits 1 or greater, the response is a hyper response with an additional disturbance. So the arousal threshold has not been met, and it's not there to create this balanced amount of breathing. And in fact, creates this hyperventilation that then leads to another apnea because the critical closing pressure is increased. Then there's another response, another apnea, and another disturbance. This is a high loop gain. Now, there's ways to look at this from a clinical point of view. let's just finish with this. Stability of the feedback control system, that's loop gain. People with high loop gain have exaggerated ventilatory response to minimal changes in CO2. Okay? Minimal changes in CO2. That's what we're seeing here. Minimal change, so there's a hyper response. Okay? In other words, an unstable control system. Now, this is what I really want to focus on. How do we as dentists try to determine whether somebody has a high loop gain? Not easy to do. Well, in my years of studying this and my years of talking with these patients and trying to bring things together, this is some of what I've come up with in terms of how this might play into it. First of all, many people with a high loop gain are going to be chronic mouth breathers. Why? Because their CO2 levels are not going to be reduced like they should, or ventilation is not going to allow for a balance of CO2, and they're going to have a hyperventilatory response, especially during sleep, with or without snoring. So a chronic mouth breather is a problem. These patients also are breath holders. They will report to you that they have breath holding episodes, or they're witnessed at having them. Not an apnea, just breath holding, just not breathing. But the key factor I found was shallow breathing, a shallow breather. Somebody who doesn't take a normal, doesn't inspire normally and expire normally. They really are very shallow breathers, which is typically followed by the last one, involuntary deep breaths or sighs. Now, some of this information comes from a book and lectures from Patrick McEwen, who wrote a book called The Oxygen Advantage, which stresses good oxygen levels vis-a-vis good nasal breathing. And when you look at breath holding, it actually becomes a positive effect in the wake state, but not in the sleep state. There's actually exercises called the Bolt test that will allow you to actually get your respiration on track. But I found that patients who are shallow breathers, who don't take a normal breath, who recognize they're a shallow breather, can sometimes during their shallow breathing actually feel as though they're not breathing or having breath holding, and will frequently have these involuntary deep breaths and sighs. And so this indicates a high loop gain. Now, how do we correct this? We can correct this with exercises. We can correct this with various breathing exercises. We can correct this with myofunctional therapy. And the major factor in all of this to correct it is to really improve on the nasal breathing that's there. So this is something that we really need to pay attention to in an effort to decrease the loop gain, to get it below 1, so that during sleep it's as regulated as it needs to be. Now, these are some of the exercises. I mentioned the Bolt test. This is the Bolt test. We inhale, exhale, and then we breath hold. How long can you breath hold for and go back to that normal pattern of breathing? This is one of the tests that is in the book Oxygen Advantage by Patrick McEwen. In the incorrect test, and what happens to people when they first start doing this, is they have normal respiration here. They breath hold for as long as they can, and then they have an exaggerated inhalation exhalation period. So if you do this with people, or you do this yourself, and this is what you do, I apologize. If this is what you do over here on the right, and not this with a breath hold, then you probably have a high loop gain. It's that simple. And so this test can help to correct some of that. There's also an exercise called the nose unblocking exercise, which just requires someone holding the nose and not breathing for a period of time, and then going to normal respiration through the nose. Typically, this is a count as high as you can get it, typically around 10 or 20 seconds. And this is what we're shooting for, how to unblock the nose with the breath hold and then the normal respiration again. I won't go into these, but this is the critical part, the Bolt test here, which helps us to improve our blood oxygen levels, stabilize our CO2, and can reduce our loop gain. The pharmacologic management of sleep apnea, which is looking at different phenotypes and endotypes, is trying different medications. I'm not going to go into these. I put this slide in here mainly for interest because it does come into play as a way of trying to improve genioglossus activity to reduce sleep apnea. That's the major thrust of what these medications, I mentioned acetaminophen before, but this is basically what these medications are intended to do. So there's a lot of research, a lot of publishing going in to the actual use of pharmacology to manage or to control sleep apnea. And they looked at these medications, and basically their effect is on the genioglossus, mainly through acetylcholine and norepinephrine channels. And that's why there's combinations, because one works on acetylcholine and the other works on norepinephrine. All right, so having said all of that, let's look at some things that are more relevant as it relates to endotyping and phenotyping. Just as a point of information, this is one of the towns in the Cinque Terre of Italy. So it all started with treating OSA with hypoglossal nerve stimulation. I don't know how familiar you are with this, but there's one thing that came out of this in terms of this treatment and predicting whether or not someone is a responder in using what is called DISE, or drug-induced sleep endoscopy. We're going to talk about that. And I'm going to show you some interesting information that has come about that can help point to us to use some of the theoretical aspects of determining a responder to this, to determining a responder to oral appliance therapy, and combining it with looking at the different phenotypes and endotypes of the patients that we're dealing with. So hypoglossal nerve stimulation is designed to stimulate the motor action of the hypoglossal through the hypoglossal nerve, cranial nerve, causes nerve contraction, first proposed 10 years ago, but they had many technical problems. And this really, 10, 15 years ago, when they were first proposing this, there were a lot of problems. So it's an implanted neurostimulator cuff or electrode on the ipsilateral side of the nerve. And it's required that there be a previous diagnosis of moderate to severe OSA. There's sensing leads that measure thoracic bioimpedance during breathing. The signal predicts inspiratory effort, and it stimulates the 12th cranial nerve to affect the genioglossus. Okay? From the journal Sleep, back in 2011, the implant procedure could take up to 3 hours from incision to closure. The state's most common used definition of surgical success is the HI less than 20 and or greater than 50% reduction in HI. This definition right here of success is called the Shear definition. It's named after Alan Shear, S-H-E-R, an otorhinolaryngologist. I resist saying ENT. Otorhinolaryngologist. And basically, this was a criteria that's been established by them as a means of determining success. So it doesn't fit with a lot of the things that we're led to believe in oral appliance therapy, but this is what their success is. And results show an HI decreased by 56% at 3 months, N1 sleep decreased, REM increased, but there was no change in the amount of N2 and N3 sleep. And this is sleep endoscopy prior to placement, DISE, drug-induced sleep endoscopy using propofol. There are some other medications that are used, but this is the common one. The patient is sedated to the point of the fact that they're not able to be aroused by speech. We do an evaluation, they do an evaluation of the nasal airway using a flexible endoscope. They place the endoscope and observe snoring and OSA. No central events can occur because this is not for central apnea. They view the areas of collapse. And the major concern that's showing up in the literature mostly is what is called concentric collapse at the retropalatal area. Now, this was a new term to me years ago, but I've done a lot of research, and this is concentric collapse. This is out of a Journal of Clinical Sleep Medicine, 2013. Here we see, this is the retropalatal area. Here we see the uvula, soft palate, posterior pharyngeal or hypopharyngeal wall, and we see an AP closure, okay? Here we see concentric collapse. Here, the entire aspect of the airway, unlike this, is collapsing inwardly and AP. So it's a combined AP lateral collapse, making the airway act almost like a sphincter. When there is concentric collapse on DISE, DICE, it's referred to as, when there's concentric collapse, the patient is deemed to not be a responder to hypoglossal nerve stimulation. Now let's take this and extrapolate it to oral appliance therapy. Could this be that the same effect in certain endotypes and certain phenotypes is the reason that these patients don't respond to oral appliance therapy? And the simple answer is absolutely. And so we need to know, how do we determine that this is occurring when we evaluate a patient for oral appliance therapy? Okay. Just to quickly give you a bird's eye view, if you're not familiar with ImThera or Inspire, it was called ImThera first. It's a plantable electrode. Let's go to the more recent one. This is it here. ImThera, which is the company Inspire Medical. This is from New England Journal of Medicine, 2014. This is the pacer here, neurostimulator, the lead cuff electrode to the hypoglossal nerve. This goes to the intercostal region. It's a pacer, which allows for sensing of a lack of respiration, which stimulates the hypoglossal to get the tongue out of the way. And this is showing the control device that turns it on, turns it off, and can control the amount of stimulation that's there. So the patient has full control over this with a remote control device. So airway stimulation, in an update in 2015, they did a lot of multi-center testing. They needed to develop a protocol. They compared it to other treatments, mainly CPAP. Here's the fallacy. Inspire is not compared to oral appliance. In fact, if the patient fails CPAP and is not given the patient who fails CPAP rather is not given an oral appliance, they go right to Inspire. It would just seem to me that it would be more practical to do the oral appliance, but that's not how the protocol works. Nonetheless, cost and insurance coverage was an issue back in 2015. It's becoming less of an issue. More companies are approving it for treatment, but it has to be preceded by DICE beforehand. And this shows what it does. Here's retropalatal. Keep in mind this area is being important. You know, it's amazing how things kind of go full circle. Back when I first got into this field back in the early 80s, retropalatal or palatal obstruction was the big topic. No one paid attention to the tongue. It was all about the soft palate. Then that fell away when they said, oh my gosh, it's got to be the tongue. We got to pay more attention to the tongue base because it's collapsing back into the oral pharynx. And the palate went bye-bye. It just disappeared off the radar. Never got paid much attention to into the 2000s. Now we're back to paying attention to it because look what happens retropalatally. Okay, what you're seeing here, what are you seeing here? Well, you're seeing some collapse, okay? Almost looks concentric to me, but it's not quite. Here we see retroglossal airway here, and here we see the opening at the base of the tongue. So you see how the airway can open up with Inspire. So the current status from 2016 to 2018, 500 patients from 14 centers, median AHI reduced from 34 to 7, Epworth scores reduced from 12 to 7, best responders, AHI 15 to 65 and BMI less than 35, increasing age effector plus CPAP intolerant. These are kind of the criteria that are evolving, okay? Okay, you ever wonder why we dream in color or black and white? This is an interesting study that was published back in 2008. And it says that the majority of people dream in color. Only 15% people dreamed in color. Today, the majority do. A study from the University of Dundee found that 12% of us dream exclusively in black and white. And it's mostly older people like me who likely recall the days of black and white TV. I found this very interesting. I thought I'd throw it in just for your listening pleasure. So the application of all of this, of endotyping and phenotyping and the DICE situation, which all fits together, is how do we apply it to OA therapy, to oral appliance therapy? Well, let's take a look. Recognize associated and related conditions such as weight or obesity, lower limb edema, craniofacial findings. This guy is on the scale and says, well, it seems your weight is perfect. You just have to be 11 feet tall or you're 11 feet too short. Apply the findings from DICE to oral appliance therapy. And there are studies that have used nasal endoscopy to determine if with jaw repositioning the airway improves. But all of the studies, there's only a few, but the studies that are out there looking at nasal endoscopy for this are not looking at it the same way they do for Inspire. They are looking at it in the awake state mostly. And that's just a fallacy. We have to know what's going to happen as best we can during what would be induced sleep. Looking at clinical findings that are related, they look at tongue position, the Mallampati, or what's called the Friedman tongue position, width of the airway, or what's called palatal pharyngeal width, and mouth versus nasal breathing at night. So let me make some sense out of this for you in terms of how we may have more prediction based upon the endotyping and phenotyping that took place to get to Inspire, that is an outcome of using DICE to clinically predict. Well, we consider the vote classification and scoring system using DICE. This was published in Laryngoscope and the European Archives of Otorhinolaryngology. My go-to person is Dr. Eric Kerzanian, who's at the University of Southern California. Eric's a wonderful guy, lectured for a study group that we did many years ago at UCLA, but nonetheless, he and I have been communicating recently about this concentric aspect or concentric collapse of the soft palate. And there's some interesting stuff I want to share with you. First of all, the vote classification is using DICE. Now, we're not going to be equipped. We're not going to go out and get a nasal endoscope and start sedating people. And we're not going to send our patients for sedation to determine if they're oral appliance candidates, although it is done in some places. But the vote system looks at the velum or the palate, soft palate, oropharyngeal, lateral walls. T is for tongue, the tongue base, and E is for epiglottis, which they can look at with endoscopy. And he has a scoring system based on the degree of closure from 0 to 2 and a configuration, which is either AP, lateral, or concentric. So how does this play in? Where is this important? And could we predict that someone might have concentric closure of the nasopharyngeal airway? How does endotyping, phenotyping fit into it? Well, it does, because it has to do with weight and obesity. It has to do with rostral fluid flow. It has to do with craniofacial characteristics. It has to do with tongue position and tongue posture. And it has to do with the lateral aspect of the airway. So let's take a look. You're all familiar with the Mallampati score. I'm sure you look at it with every sleep patient, maybe all your patients for all I know. I did. And this is just basically their system. This is not the one that I recommend to UCLA students to use, or any other students for that matter, mainly because this involves the protrusion of the tongue. So what you're doing is you're falsely getting a picture of the oropharyngeal airway in these categories. I prefer to use the Friedman tongue position, which is one that's based upon no protrusion of the tongue, just allowing the tongue to be at rest. And so here we see FT1, FTP1, FTP2, A and 2B. I think he likes Shakespeare. He has 2A or 2B. I'm not sure that resonated. FT3, FTP3, and FTP4. This is critical. This is going to help us to define endotypically what's happening with a patient mechanistically with their tongue position, okay? Then we look at determinants, upper airway determinants for OA therapy. Now, back in the early days, many years ago, I looked at a lot of this. I dealt with this. I still do. But what we have to look at is letter D. I have it in red. The width of the palatal pharyngeal area, this area here. Now we know this is the tonsillar crypt here, so we see tonsils, and C is the distance between the anterior pillars. This is typically called the posterior pillars, but this width is what's critical, okay? The narrower this is, the worse it's gonna be. Now, when we look at Mallampati, let's go back, FTP or Friedman tongue position, in combination with this width, we are having the beginnings of determining whether or not a patient may have the risk for concentric closure of the palatal, of the retropalatal area. If we have that as a case, then we should know that they are not going to be a very favorable responder to oral appliance therapy. It is that simple. So here we see from an article in 2003, and I use this data in all of my lectures as part of my clinical examination. I remember discussing this when I was with you in 2019, October. This is based on palatal pharyngeal arch width. I went back and re-reviewed the article. They classify it as 1, 2, 3, and 4. Notice I've drawn red arrows to show the palatal pharyngeal arch width as wide open, less open, 50% closed, almost totally closed. These two do two things. Number one, if the patient has not had a sleep study, the patient has not had an inquiry to whether or not they have OSA, these two have a high predilection, high risk for OSA. Number two, these patients are not going to be good responders to oral appliance therapy. It's that simple. And I've had conversations via email based on articles I just presented to you about DICE and about VOTE with Dr. Kazarian, and he confirms the same thing. He actually said to me in one email, he said, don't get so focused on the concentric closure. It's the lateral wall width or the palatal arch width that's the critical factor. So where do we see this mostly? Are we going to see it in mostly thin people? It's possible, but they may mostly be overweight patients. Now, we got to take into consideration the tonsils could play a role in this if they are enlarged. We're discounting that at this point, okay? So patients who have more of this with a Friedman tongue position 3 or 4 are going to more likely have concentric closure of the airway. These may be patients who are also more overweight, okay? And so you may see more of this as opposed to this, all right? Other procedures may also come into play or may help, should be reviewed as adjunctive procedures. So palatal and maxillary expansion can be helpful. Why? Because it's going to take, I'm going to go back to here, it can take and make this wider. Eric said to me in an email, he said he hasn't found a good way to deal with this, and I emailed him back. I haven't heard back from him recently, but I emailed him back some of my thinking, okay? Palatal maxillary expansion, whether there's a crossbite or not, widening the maxilla. Myofunctional tongue therapy, which helps to bring the tongue base forward, which can help. Surgery to consider. This may need to be adjunctive to the oral appliance, like UPPP. One article on DICE and on the endotyping, phenotyping of patients for Inspire looked at UPPP as being one of the ways to resolve the concentric closure. So we know that there's joint or multiple procedures that may be helpful. Another one is called transpalatal advancement pharyngoplasty. I'm going to look at that. We're going to look at that. The goal is to widen the airway, improve that palatal pharyngeal width, improve tongue position, increase nasal breathing, and lessen risk for concentric collapse. All of these things fit together. So you all are familiar with UPPP, I'm sure, where this happens. That gives it a little bit of additional width, but not as effective as a procedure called transpalatal advancement pharyngoplasty, where a portion of the hard palate is excised and brought forward. This is in lieu of, say, an orthodontic surgical procedure. The soft palate is advanced forward. It's more successful than UPPP. It also affects the airway in AP as well as lateral aspect. So patients who have this done have actually shown an AP improvement as well as a lateral improvement. And what is the concentric collapse? It's a combination of AP and lateral. They may continue to snore, but not as much. Scar tissue will occur as associated with UPPP and may require a small soft tissue surgery. So some redundant tissue may need to be removed. This is the procedure known as transpalatal advancement pharyngoplasty. Okay, sorry. This is what it is. A flap is reflected, a small wedge of bone is removed, and this is moved. This section is now brought forward. By this being brought forward, what happens is that it increases the AP dimension retropalatally here, and it also creates a tension that allows for width of that palatal pharyngeal area. It's not radical, but it's significant enough that it may get us out of the woods of the concentric collapse. So there's another thing that can be done, and this has been shown in some articles. I just want to make you aware of this, where oral appliance options consider the use of a trial oral appliance before using a more durable oral appliance. There's one study that's been done by a group in San Diego called Better Night, where they looked at this and they found that when they used this ahead of time and the results proved to be beneficial, it was a win-win all the way around. You can do DICE with the trial oral appliance. They used MyTap in one study versus mandibular thrust with improvement in retropalatal. That was published in the Journal of Clinical Sleep Medicine in 2020 on this technique. The oral appliance, they felt, gave them a little bit of a more stable position as opposed to just arbitrarily moving the mandible with a thrusting procedure. And it may help with OA success. These articles here looked at it. But again, these two articles that looked at nasal endoscopy to predict success with oral appliance were done in the awake state, and neither one looked at the retropalatal area. So if we combine a lot of these things together, we may take those endotypes that are out there that have not only mechanical, but the ones that also in the phenotypes have anatomical issues, and we can change a lot of things for the better with these types of patients. Now, two of the appliances that are used, the study from Better Night in San Diego used the apnea guard, which I'm in big favor of. This is a very simple one to use. And the reason I like this one is because it comes in varying verticals. So you can change the vertical on it as you deem it appropriate. This is the MyTap appliance that was used in the one study. We also need to consider personalized medicine, which is playing into the endotyping, phenotyping, because it takes into consideration the race of the patient, it considers the craniofacial features, it considers their environment, it considers other things that are all fitting these things together. And so this is called the P4 theory. It's predictive, meaning can we predict an outcome, which is what I was trying to hopefully transfer to you tonight. Is it preventative? Can we prevent things from happening ahead of time? If not, how do we prevent them from reoccurring? Are we personalizing the treatment? Again, based upon the phenotype and the endotype of the patient. And the patient becomes participatory because we give them options as far as what they can be involved in or what treatment they can select. These are the two articles that deal with P4 theory and personalized medicine. We also have to look at quality of life and health-related quality of life because, you know, the quality of life or the health-related quality of life that patients are going to experience can vary based upon associated comorbidities they may have. I feel it's important to ask a patient not what can I do for you, but what is important to you. So the take-home message is there is more to OA success than just repositioning of the mandible. We need to look at all of the various things that play into the endotyping and phenotyping of these patients as we begin to make these decisions. You've probably been making them all along. You just didn't realize that there were boxes or categories they could be looked at. We have to look at and consider all aspects clinically, apply the clinical findings to what is seen with DICE, especially in the retropalatal area, and incorporate adjunctive therapies when indicated and when deemed beneficial. And that means developing a referral network of surgeons and myofunctional therapists and otorhinolaryngologists who can all help to make things work better for us. So learning from your mistakes and experiences, really? You might learn what not to do again. You still may not know what to do next. So the attention that's paid to the various categories within endotyping and phenotyping and how we can apply that to our clinical judgment is going to help us to better determine what we do next as opposed to learning from our mistakes. I hope this has been beneficial to you. I know it's a lot of material. I tried to tie a lot of different things together, and I thank you very much for attending this evening. David, I'll turn it back to you.
Well, thank you, Dennis.